I'd like to welcome Dr. Ari Fukaya, who is a clinical professor in the Division of Vascular Surgery at Stanford University. She's also one of the rising stars in venous disease worldwide. So thank you very much to agreeing to this podcast.
Thanks, Danielle, for such a warm introduction.
So you've been doing some really exciting work. Can you talk a little bit about some of your differential for patients with venous insufficiency?
So I think when you say chronic venous disease or venous insufficiency, we all assume that there's something wrong with the vein itself, the anatomy of the vein. Is there some reflux, a valve that's not working? Is there anything, there's clots, or there's what we call post-thrombotic changes, where there's chronic changes due to scarring of the vein tissue. So we think about those things in terms of chronic venous disease. However, that's an anatomic issue that causes venous disease symptoms. However, when you think about what does that do, it causes venous hypertension. And that venous hypertension is what really causes all the symptoms and the downstream effects. But there's other things that can cause venous hypertension, even when the anatomy is intact. So you may have veins that are maybe a little dilated, but they're not refluxing a ton, maybe just a little bit. Or you may not really have clots in the past or anything like that, but maybe a little bit of compression due to other things that causes the veins to have pressures. And so I've been thinking about this a lot, and how do you differentiate one versus the other? I think a clean way to think about it is there a structural venous insufficiency when there is an anatomical problem, or is it a functional venous insufficiency when the anatomy is not, may not be perfect, but the anatomy is not what's driving the issue? And obviously, you can have a combination. You could have both structural and functional, and it may be a 50-50 ratio, it may be a 20-80 ratio, or it may be a 10-90 issue. So I think when we talk about venous disease, it's very important to factor in not just the anatomical part, but the functional part, and understand how much of that is actually contributing to the pathology.
Well, I know you've been thinking a lot about this. Could you give some examples?
Sure. So let me share a slide because I think that might be helpful. One second. Where did my, here we go. Okay. So I have a slide up here which shows some of the things we can think of when we talk about functional venous insufficiency. So again, these are things where it's problems that are not anatomical, but can increase venous pressures. So a very big one that we see all the time is something that increases central venous pressures. So that could be due to heart failure. If you have especially right-sided heart failure, that can increase venous pressures. Similar to that, if you have obstructive sleep apnea, that actually can cause increased pressures, and that can cause venous hypertension. People who have obstructive sleep apnea, if you think about it all, we often tell our patients to elevate their legs because that reduces the pressure in their legs. But if you have sleep apnea and you have increased central pressures, elevating your legs may not really increase the venous return. And so if you think, when they're sleeping, however many 6 hours to 8 hours a day, they're not really given that venous pressure relief they would have if they didn't have sleep apnea. So that's a big one. If you have obesity, that can cause increased abdominal pressures. That can, if you think about your abdominal pressures too, in your upright position, in your lying position, that we know with, for example, when we look at the IVC on CAT scan, if you see it in an upright position versus in a lying position, how hydrated or dehydrated are. We know how much the veins can be compressed and what kind of pressures are on it. So again, obesity can put a lot of pressure on the veins. So those are some things that can cause increased central pressures. And then that's sort of pushing all that pressure down. But then there's things that don't help the blood return. So for example, if you're just sitting all the time, you develop what's called dependent edema. And that is not that the valves are not working and your blood's not going back. It's just sitting there. It's stagnant. And that may be due to just your position. However, a big component can be the limited range of motion in your ankles. It's really common that people can't move their ankles very well. And what's interesting is when you start looking at people's ankle movements, you realize a lot of people are good at sort of flexing their ankles and pulling their feet up. But in order to really engage that calf muscle pump, you have to be able to step down and contract your calf muscles. And you'd be surprised how many people just have really, really stiff calves, that all their ankle movement is driven by their anterior tibialis muscle contracting and not their calf muscles. So these people are not using their calf muscles. Also, a lot of people have very stiff feet. They're wearing their shoes all the time. They don't move their toes. So they don't move any of their metatarsal joints or their actual toes themselves. And when you think about that venous plexus in the plantar foot, there's a lot of blood that goes there. Because the deep vein, that's where the deep vein and the superficial vein sort of connect. And that pool of blood can really just sit there and not move unless some of your intrinsic muscles in your feet move. And without that motion, everything kind of sits there. So there's sort of a descending venous hypertension where you've got increased pressures, but there's also a lack of ascending force, which causes venous hypertension, and those can be a musculoskeletal thing. And on top of that, you can have sort of your lymphatic dysfunction, which could be due to, again, a structural cause or a functional cause. But all of that, a lot of people have many elements of these things that can cause the functional venous insufficiency. And what's really cool about this is if you diagnose it and you can help the patients, whether it's by showing them exercises of what to do, and exercise really, really way, helping them with weight loss or, identifying they have sleep apnea and getting them a CPAP machine. It's really surprising how much patients can feel better. Their symptoms significantly improve, even if you didn't do anything to their legs. So I do think there's a big component of venous hypertension caused by other things.
So you were talking about some of the functional causes, but how about some of the medications that are involved? Because medications also can play a significant role.
Absolutely, absolutely. So I am going to share a different slide. So here is a list of medications. There may be others, but this is sort of a classic list of medication that can cause swelling. And there's a lot of drugs that people are commonly on. So for example, a calcium channel blocker, like an amlodipine. You take people off of amlodipine and there's a lot of leg swelling you can improve. And it's not that you should just take them off. There's a lot of good blood pressure medications you can exchange them for. So just really making sure if they come in with leg swelling, is there a calcium channel blocker on board is very important. Also, a lot of people, this happens all the time where they just have discomfort in their legs. They've got some kind of pain. You're not really sure what it is, but oftentimes they get put on medication like gabapentin. And, it actually can cause a lot of leg swelling. So gabapentin is another common one that you really want to make sure if they should be on or not. There's a whole list. Sometimes it could be chemo drugs. Sometimes it could be Parkinson drugs. A lot of the antipsychotics can cause leg swelling. So it's just good to do a good med rec. And sometimes you might not know if every single drug has a side effect, leg swelling as a side effect. But even kind of touching on some of the ones that I mentioned, sometimes even NSAIDs can cause leg swelling. So those are some drugs that it's worth visiting to see if they are the cause. And that can often really improve. I've seen so many patients where we just take off the amlodipine and their complaints are better.
Absolutely. No, I could not agree more. And that's a common medication that's prescribed. And um, yes, we see it very, very often that the patients, after you stop it or change them to another medication in cooperation with their rest of the routine, that they actually do get better. So I agree with you. I want to actually talk a little bit about patient compliance also. Um,
Mhm.
you were saying that exercise can be important. Sometimes the patients may be sitting a lot. I find a lot of patients who are sitting a lot for one reason or another. Um, they may have their heart failure might be under good control, their renal failure might be under maybe fine. Um, but sometimes getting the patients to comply with these can be hard. Uh, Getting to wear stockings can be hard, but even getting them to elevate their legs sometimes, uh, sometimes some older patients may not want to. How do you get the patient to comply with some of these also?
I think that's you're getting to the key, like the important part, because you can give them all the information, but if they don't do it, it's useless. So I think it's very important to give them practical tips. And, you kind of have to do an individualistic assessment. But, for example, I have a lot of workers just sit at their desk all day in front of the computer and so for these patients, and then there's a myth that, these standing desks are really good for you. It's excellent for the back, but, it's not really good for venuses. So what I tell patients is try to get a small ottoman or a box that you can put under your desk. And if you go to any sort of big box stores or even online, you can often find very convenient ottoman, a storage box ottoman. And I recommend, my personal preference is a 17-inch high ottoman, and it fits right under the desk, almost any desk. If the desk is small, you could even get a smaller ottoman, like a 15-inch, but it fits right under a desk. And then what happens is when you sit at your desk, then you're going to put your leg on it. However, when you sit at your desk and you put your leg up, unless you're very limber, your hamstrings are tight, whatnot, it's kind of hard to sit. So I often recommend to my desk worker patients that in order to sit comfortably with your legs elevated, you should get a good task chair. So a task chair that has a little bit of ability to recline backwards, ideally with a headrest, because then you can really kind of lean back. I don't know if you could see, I have a task chair such as. So I have the same setup where I put my leg up a little bit. I can lean back sort of like this. So then it's easier to put your leg up. In order to do that and work comfortably, you have to be able to pull your monitor forward a little bit, pull your keyboard forward a little bit. So you're not kind of working in this position where most computer workers are. You're kind of sort of lying it, working sort of in this position. It's actually really good for your back and neck too, so you're not all crunched up. So, that's an easy way to elevate your legs during work. Because if you think about it, keeping your legs down in a sitting position, that the venous pressure there is probably about 60 millimercuries. Versus if you elevate it on an ottoman or something, it's still high probably, but it might go down to like 30 to 40. Versus if you have it down, 60 to 70, and you do that 8 hours a day or something, that's going to have a cumulative difference. So I think that that sort of tip, that's an easy tip for a desk worker. For older people who may be sitting and they want to do exercises, but they're not really going to go to the gym or anything. I have TheraBands in my office that I cut for them. So I give them like these pieces of TheraBands so they could do a little bit of resistance exercises, even if they're sitting on a couch or something. So, you just put a resistance band on your foot, kind of pull it back like you're on a horse and you've got reins, and have them sort of push down on it and kind of, because that really helps with the ankle mobility. And, and I also have a little video I share with them. It's like a 2-minute video of all the exercises I want them to do. So I'd often be like, because it's hard to know what to do. You can be told, do your ankle exercises, but you don't really know what they are. So I usually give them a combination of my little video and the resistance bands and show them exercises. And if they're a little bit more active, I'll show them, exercises they can do at the gym and things like that. But there's ways you can entice the people who are not even who are sedentary to get those movements in. And then also, like, the compression compliance, obviously, if you tell them to wear 20 to 30 or 30 to 40, it's going to be really hard. So I try to ease them into it by finding them a very comfortable sock they can wear that may only have a compression level of about 8 to 15 or like a really low one, and get them into the habit of it's not that bad to wear these things. And then if I can work myself up to a higher level, that's great. But surprisingly, these patients, the older patients with the bad edema, you don't really need to even put them in a 20 to 30. You put them in like an 8 to 15 compression. And if they wear it consistently and do the other stuff, their leg swelling is significantly better. So I think we often opt to do the best possible option. But even if you go with like the easy entry, it can make a difference. And the thing that I believe motivates the patient to continue is that they actually see a benefit. They're like, my legs feel better. And it's because Fukaya told me to do this, and I think I started doing it. It feels better. Then, if it makes you feel better, you're more likely to continue. So I try to make the entry bar low for the patients.
I like that idea. Quite frankly, I like the very practical tips that you can use for different patients. I think that's really important, getting to know exactly what's going on with with your patient. I love the list that you gave of the medications, because we often forget that very common medications that many of our patients are on can really affect the lower extremity venous hypertension. And I love the idea that it's not just chronic venous insufficiency, but the venous hypertension that we really need to be focused upon, because it really helps underlie the patient's pathophysiology, but more importantly, their symptoms.
Yes, and I think it empowers them because, they don't want to get worse. They're struggling with their symptoms. And if you could give them practical tips that can help, a lot of patients want to get better. So they'll do it.
Thank you so much for agreeing to do this podcast. It was really great.
Absolutely. Absolutely. I hope I was able to kind of sprinkle in some of my vascular medicine take into venous disease.